very unfair from Joy to mention that she's in a warm country. I'm so jealous. Hello, everyone. Welcome to our 12th online workshop. Today, we're going to talk about planning a family. I'm Patrick, and I'm a patient and volunteer with Alport UK, and I'll be hosting today's workshop along with a little bit of help, which I will introduce later. As always, we have some fascinating specialists here to explain a topic really important to Alport syndrome. Today, it's the reproductive options for people with Alport syndrome and what to expect when embarking on a pregnancy with kidney disease. We'll also cover the specific challenges encountered with a disease like Alport syndrome. This is by far one of our most requested topics. It's ignited a wave of questions on social media, which we'll get to in a moment. So thank you to all the people that have been sending those in. And of course, if you do have any during the workshop, we'd love those too. We're very privileged to have Frances joining us, as well as Matt. I think at this point, she has been in more online workshops than I have. So fantastic to have Frances and Matt here. Now that's over, let's begin by introducing our esteemed guests. It is with great pleasure that I welcome, I think for the first time, a fellow patient to the podcast series. Aura will join me in putting the questions to the speakers, as I've said. She is in her final year at Peter Simons College in Winchester and is hoping to study medicine at university next year. Like me, she has Alport syndrome, so we're just delighted to have someone else helping me out today. Frances Flinter, who many of you I'm sure will know already, Emeritus Professor of Clinical Genetics at Guy's and St Thomas's Hospital. And of course, Dr. Matt Hall, on for the first time. He's a consultant nephrologist at Nottingham University Hospitals and clinical lead of the UK Pregnancy and Kidney Disease Rare Disease Group. Right, I think all that out of the way, it's time to get to the presentations. Frances, are you ready to present? Looks like we can see the screen now. Just need to unmute and I think we're good to go. Still can't hear you, I'm afraid, Frances. I think you're unmuted now.
I'm muted by the host. Yes, I couldn't unmute myself. Thanks very much, Patrick.
No worries. Over to you.
Right. So I've been given quite a challenge today, which is to talk about all the different forms of inheritance, all the different reproductive options that people can consider if they want to have a family. And nothing that I'm going to say this afternoon can in any way replace the value of having a personalised counselling appointment. So if this is something you'd like to know more about, I do very strongly urge you to seek a referral to your local genetics department. And if you're in the UK, any health professional, any doctor or nurse can refer you there. And you will have a much longer appointment just to discuss the issues that are relevant to you than I've been allowed to have to talk to this afternoon. And the other thing I want to say before I start is that everybody is different and everybody makes different choices, and that's absolutely fine. And as a geneticist, I've always been trained to be completely non-directive. So if you go to your genetics department, people there will never say to you, this is what I think you should do. They will tell you what the different options are, what the pros and cons are, but it's up to you and your partner, if you have one, to decide what's best for you. And I'm cautious about this because I know that even mentioning the possibility of prenatal diagnosis will be upsetting for some people, whereas for other people, they will say, well, I wouldn't even consider starting a family unless I knew that that was an option available to me. So let's just recognise that everybody is coming from a different place and will make very different decisions. I'm also going to try and diffuse some of the debate and controversies that there have been about some of the words and language that we use. I hope that will be helpful. So if you go to a genetics clinic, what's going to happen? Well, the staff there are there to help you understand the genetics of your family's type of Alport syndrome. So they'll start off by taking a family history, and it's helpful if you can take as much information as possible with you. If it's appropriate and you'd like to pursue it, they can arrange genetic testing for you. It may well take several months before you get the results, and the staff will be very happy to explain those results to you. And if a particular alteration has been identified that they feel is significant, the staff there can help you identify from your family tree relatives who might also benefit or might wish to consider genetic testing, and they can help approach them. And they'll discuss with you what options are available to you as and when you're thinking about having children. But as I emphasize, the decisions are entirely yours. So why might people consider genetic tests? They may already have a reasonably confident clinical diagnosis. But what a genetic test can do sometimes is identify which gene is involved in your family, and therefore what pattern of inheritance is that is relevant in your case. This may take, this may take many months, and some people get inconclusive results. We know that's very frustrating, but each of us has around 1 million variants in our DNA, and the vast majority of them have no effect on the functioning of the gene in which they occur. So the laboratory does a huge amount of work filtering out alterations that are not significant. But the ones they're left with, they may not be sure whether they're significant or not. And we really do understand that patients find this particularly puzzling and difficult to understand if the experts are saying there's an alteration in your DNA, but we're really not sure what it means. The language that we use when we're talking about variants is that they may be significant or not significant, or variants of uncertain significance. Variants of uncertain significance are sometimes referred to as VUSes or VUSes. It's a terrible name, but that's what it stands for. And variants that are significant are sometimes called mutations. If there's an alteration found in your DNA, but we're not sure whether or not it's significant, what we may do is go on and test a number of members in your family. And what we're looking for is to see whether the results are different in affected members of the family from unaffected members of the family. And sometimes that enables us to work out whether or not an alteration that's been identified is significant. So when you get your genetic test report, what's it going to tell you? Well, it'll start off by telling you which genes have been screened. If they just looked at one gene because they can tell from the family history which gene to target, or have they looked at all the type 4 collagen genes that can be involved in Alport syndrome? And there'll be a bit of technical discussion about which method they use to screen for the mutations. The variants are then described increasingly now as falling into one of 5 classes. Any that fall into class 1 and class 2 won't be mentioned on the report. They're the ones that we think probably are not significant. As I said, there'll be around 1 million of them. So the report would be very long if we had to talk about all of those. But we do mention variants of uncertain significance because we know that in 2 or 3 years' time, we may have more knowledge about that particular variant and may be able to change its classification into either something that's significant or something that we can ignore. And the class 4 and class 5 changes are the ones that are most significant. They're probably disease causing or definitely disease causing. And if they're in that last group, it'll be because we've seen them several times before in other families. If some of your relatives are tested, then the report may be able to say whether the variant you've got's been inherited from your mother or father or both, or a phrase you might come across is de novo. That means it's just started in you. It's a new mutation in you, and it's not one that you've inherited from your parents. Now, I know there's been a lot of discussion about can we predict the severity of your Alports once we know which gene has an alteration and what the alteration in that gene is. And the answer is, well, we can a bit, but not really with very much confidence, because the severity of your condition is influenced by so many different factors. In part, yes, it's the alteration that you have in the Alport gene, but there will be alterations in other genes as well, and also a number of things in the environment, some of which we don't even yet understand, that will also have an effect on the likely course of your disease. And perhaps the most important thing to say is, of course, if you get diagnosed young and you're offered treatment and you comply with that treatment, you can very significantly alter the course of your clinical disease yourself. And if you take tablets prescribed for high blood pressure or protein in the urine, you can postpone significant kidney disease by a number of years. Now, for those of you who are interested in learning a bit more about genetics, I suggest you go to the Health Education England website. There's a whole section of little courses there, some of them as short as just 2-minute videos that tell you about the different patterns of inheritance. And I know a lot of patients find those very, very helpful, although in fact they were originally designed to help non-geneticists, clinicians, doctors and nurses learn more about genetics. I've also written a short blog on that website about things that you can consider when you're being offered a genetic test. So let's go on now to consider what the options are for people who are thinking about starting a family. And I've listed them all here. I'm not going to have time to talk in great detail about all of them. But the first one will be, well, take a chance. You know what your family history is, you know what the chances are of your children being affected, and most important of all, you know the benefits of early diagnosis and good prompt clinical management, and may feel that that's the way you would like to go, with the knowledge that you can turn to the children's kidney doctors to look after your children if in fact you turn out to be affected. Now, some people like to know before they have a baby whether or not the pregnancy is going to be affected, and so they may get pregnant and after a few weeks have a test done to see whether or not the baby has inherited Alport syndrome. Other people may prefer to wait until the baby's born and have a test then so that they know whether or not the baby is affected. Egg donation and sperm donation is something that a few people consider. I'm not going to say very much more about it because it's something you can discuss with your genetic counsellor if that's what you would want to consider. But for a woman with X-linked Alports, choosing to get pregnant with an egg from an egg donor would get round the risk of her children inheriting Alports. Likewise, if a couple has had a baby with recessive Alports, they could in a future pregnancy choose to use sperm from a sperm donor who doesn't have Alports himself or a family history of Alports. And once again, that would minimise the chances of a child inheriting Alports. Some couples choose to adopt children rather than have children who are genetically related to them, and others may decide that their family is complete, they're not going to have any children, or they're not going to have any more children. And I will say rather more about the end about the final option, pre-implantation genetic diagnosis, which uses fertility treatment, IVF, so that embryos can be tested at a very early stage before embarking on a pregnancy. Now let's just think a bit more about the chances of having an affected child for the different types of Alport syndrome. And please remember that only one of these will be relevant to each of you. So if you know you've got X-linked Alport syndrome, what are the chances of your children being affected? Now, if you're a woman, you've got 2 X chromosomes. And if you've got an alteration in the Alport gene on one of your X chromosomes, we know that the other one usually is normal, it doesn't have an alteration. And when you have children, they will inherit one or other of your X chromosomes. So any child will have a 50-50 chance of inheriting your mutation. That means any son will have a 50% chance of being affected, and any daughter will have a 50% chance of inheriting that mutation. It's different if you're a man, because men have 1 X and 1 Y chromosome. So if a man passes on his X chromosome, that baby will be a daughter, and you can see she must inherit his Alport's mutation. Whereas if a man passes on his Y chromosome, that baby will be male and will be unaffected because that baby boy will inherit his X chromosome from his mother. You may see people drawing family trees that look a bit like this. This is what we call a pedigree of X-linked inheritance. And as I've said, women have 2 X chromosomes, and because they've got a second normal copy of the gene, they're often less affected with X-linked conditions. And this lady here has had 2 daughters and 2 sons. She's passed on her mutation to one of her 2 daughters and to one of her 2 sons. But it doesn't always work out exactly that way. I often say chance has no memory, and just because your first son was affected doesn't mean to say the second one will be unaffected. He will have a 50-50 chance, or a 1 in 2 chance of being affected when he is conceived. And this male here has X-linked Alports. His sons cannot be affected. X-linked conditions cannot be passed down from father to son. But when a man with an X-linked condition has a daughter, she will inevitably inherit his mutation. So as I've said, females with X-linked Alport syndrome have 2 X chromosomes, but in every cell in their body, one of their X chromosomes is switched off. We call that being inactivated, because you actually only need 1 X chromosome working in each cell. Men only have 1 X chromosome in each cell. And we think this is why the way in which women are affected with Alport is so incredibly variable. I suppose if you're lucky, you mostly switch off the X chromosome that has the altered Alport gene on it, and you're mostly running on the X chromosome that has the normal Alport gene. Whereas if you're unlucky, you mainly you may predominantly switch off your normal X chromosome, and that means the features of Alports will be more obvious. Almost all women with X-linked Alports have blood in their urine. We call that hematuria. Some have protein in their urine, proteinuria, and they're at risk of developing high blood pressure. So it's very important their urine and blood pressure are monitored at least once a year. And whilst the majority of women with X-linked Alport syndrome retain reasonable kidney function, they do have a risk of renal failure. And that risk of kidney failure can be reduced by regular screening and appropriate treatment. I'm going to try and address the very controversial topic of the use of the word carriers. A carrier is a word that's been around in the genetics language for a very long time. And a carrier is someone who has a genetic variant that may or may not affect their health, but it has implications for their children. So some people will use that term for women who have an X-linked variant, and for men or women who have a single variant on one of the numbered chromosomes, call those the autosome. Carriers are often asymptomatic, or if they are affected, they're usually more mildly affected. And if a carrier becomes significantly symptomatic, some people refer to them as being manifesting carriers. But I know that in many places, particularly in America, the consensus now is to avoid the use of the word carrier and refer to people being affected, regardless of whether or not they have significant symptoms. And there's good reason for doing this, because there is concern that if you say somebody is a carrier, they may think they're just a carrier and therefore not have the screening that is so important and so useful. On the other hand, if we see children who have blood in their urine all the time but are otherwise completely fit and well, and we do a genetic test that shows that it's a girl with an X-linked variant or a girl or a boy with a single autosomal variant, we know that they're most likely to retain normal kidney function through their lives. And so labeling them as having Alport syndrome may be unhelpful and may make families worry that the prognosis is worse than it actually is. So this is a very difficult issue. And rather than getting tied up in arguments about the language, I think the most important thing is that people understand the implications of whatever their genetic makeup is. So let's talk a bit more about autosomal inheritance. This is the genes that are on the numbered chromosomes, and all our chromosomes come in pairs, so we all have 2 copies of each autosomal gene. Now, there's a difference between autosomal recessive conditions and autosomal dominant conditions. Diseases that only occur when both copies of a gene are altered are called autosomal recessive conditions, whereas diseases that occur when only one copy is altered are called autosomal dominant conditions. And really, we need a word that describes the implications of having a single alteration that is associated with some risks, but not necessarily the full syndrome. And I suggest, and it would be interesting to know what patients think, that something like a kidney disease susceptibility factor or a kidney disease predisposition gene might help us confidently steer a path through that sort of middle ground, that grey area. We know that having an alteration in one of the 2 autosomal genes causes people to have blood in their urine nearly always, and it increases their risk of developing a protein leak into the urine and high blood pressure. And we know that it's a risk factor for kidney disease in later life. But we also know that the majority of people who just have a single autosomal variant keep normal kidney function throughout their lives. It's only a minority that develop kidney failure. And we also know that these people are not at risk of the hearing loss or the eye signs associated with Alport syndrome. Although as they get older, they may of course develop age-related hearing loss, which is slightly different. Come what may, the important thing is that they have regular clinical screening and prompt treatment of any protein leak or high blood pressure. So what are the chances of having an affected child if a couple has previously had a child with autosomal recessive Alport syndrome? That means that we know both patients have a single mutation on one of the autosomes. Well, the answer is 1 chance in 4, or 25%. Doesn't matter about the child's sex. They also have 2 chances in 4, or a 50% chance of having a child who inherits 1 copy of the altered gene. And they have 1 chance in 4, or a 25% chance of having a child who is both unaffected and doesn't carry any copies of the altered gene. That's assuming that in the next pregnancy, it's the same two parents together again. So here's a family tree showing autosomal recessive inheritance. And the convention is that carriers are marked with a little dot like this. The squares are males and the circles are females. And only children who inherit the altered gene from both parents are fully coloured in because they develop Alport syndrome. And with autosomal recessive inheritance, often the affected individuals are just all in one generation. You don't tend to see a family history of kidney disease going back for many generations quite so often, because it's less likely that in previous generations carriers will have got together with other carriers and had children. And we see an increased chance of autosomal recessive inheritance occurring when there's intermarriage within families, for example, people marrying their cousin. We refer to that as consanguinity. So the next question that some patients have asked is, what are the chances of having an affected child if one parent has autosomal recessive Alport syndrome? So one parent has got an alteration in both copies of that Alport gene. The chance of having a child who is affected with autosomal recessive syndrome is very small, but every child they have will be what could be called a carrier. They will have a single altered copy and they must have lifelong clinical screening. Sometimes people come to the clinic and say, well, I know I've got autosomal recessive Alport syndrome. Can you test my partner to see if he's a carrier? And we, in fact, only offer carrier tests to unaffected partners if they either have a positive family history of Alport or if the couple are related to each other, if they're something like cousins. And the reason for that is it's extremely hard to test somebody with no family history and no history of Alport syndrome, because you'll be faced with around 1 million variants that you've got to work your way through. And even if there is a variant in one of the Alport genes, there's a very high chance that we won't be able to classify it as either significant or insignificant. And so that means actually in practice, we can't give people a useful answer. It tends just to cause even more concern than answers to the questions being asked. So we can calculate what an unaffected partner's chance of being a carrier is. It'll be very small, and that couple's chance of having a child with recessive Alport syndrome will also be very small. Now, finally, I'm going to look at what some people refer to as autosomal dominant Alport syndrome. It's actually a term I don't like because patients with this type of Alports, although they have a risk of developing kidney disease, they're not at risk of hearing problems or eye signs. So they don't really have a syndrome. That's what the word syndrome means. It's a constellation of different features which all add up together to a particular condition. But any adult who has a single alteration in one of the autosomal genes will have a 50-50 chance of passing that alteration on each time they have a child, regardless of the child's sex. So this lady here has had a daughter who hasn't inherited it, a son who has, and a daughter who hasn't. And it's only her children who inherited her alteration who went on to pass it on to some of their children. And once again, the most important message is screening. Clinical screening is really important. And as I've said already, chance has no memory. Just because you threw a 6 once when you throw the dice has no influence on what you'll get next time you throw the dice. So let's move on now to consider the options that people can think about when they want to have children. Prenatal diagnosis is probably the one that people ask us about most often. And first we have to think, well, is there a test we can offer them? And the answer is there will only be a test if you've had genetic testing and we've been able to find out what the alteration is in your DNA. So if this is something that you think you might like to consider, it's really important that you go to the geneticist well in advance to have a blood test done so that the genetic testing can be initiated. So please ask to see a geneticist well before you plan to start having a family. And if you have a partner, discuss it with them. Are you in agreement about this? Do you both want to go down that path? Will knowledge of your own genetic makeup affect the management of your pregnancy? Maybe it would help you prepare for the possibility of the birth of an affected child. Or maybe you would wish to consider prenatal diagnosis with a view to possibly making that incredibly difficult decision, thinking about terminating an affected pregnancy. And when you go to the clinic, the people you see will ask you about what you know about Alport syndrome, what is your own family's experience of it? What questions do you have? Do you want to know more about how Alports can be treated these days? And they will also find out, as well as what your knowledge is about the condition, they'll want to know what's your background, what do people from your culture generally prefer to do, what sort of support do you have in and amongst your friends and relatives for whatever decision you're thinking about making. So do please write down your questions before you go to the genetics. When we're talking about prenatal diagnosis, there are generally two different types to consider. First of all, invasive procedures. This is when a small sample is taken to test the chorion villus biopsy. That's done at about 10, 12 weeks of pregnancy. There's amniocentesis, which you may have heard of, and occasionally we take a sample of the baby's blood from the umbilical cord. There are also some non-invasive tests. An ultrasound scan may enable us to tell you the sex of the pregnancy. And I'm going to say a little bit about non-invasive prenatal testing, because this is something slightly new, but potentially has something very interesting to offer to people who are cautious about more invasive procedures. So the invasive procedures, both chorion villus biopsy and amniocentesis, basically involve obtaining a few of the fetal cells so that the DNA can be extracted and tested. And these tests have a small risk of causing a miscarriage, probably about 1 in 200 people who has a CVS or an amniocentesis will miscarry afterwards as a consequence of having that procedure. And that risk will put some people off from having a procedure done. So with a chorion villus biopsy, we take a small sample from the placenta here. With an amniocentesis, a small needle is introduced through the tummy to take a small sample of the fluid that surrounds the baby. You might be interested to know that the fluid surrounding the baby is basically the baby's urine. And that urine contains some cells which have the same genetic makeup as the baby. Or we may take a sample from the umbilical cord, which will have the same blood supply as the baby. We've already talked about the fact that there is a small risk that the procedure could cause miscarriage. And for some people, the information that test would generate is too late for them. They wouldn't want to do something at that stage. And we're well aware of the fact that going through prenatal diagnosis can cause a lot of anxiety. Now, just a little bit about fetal DNA in the maternal circulation. It may surprise you to know that tiny amounts of the baby's DNA actually escape into the mother's bloodstream, and we can pick them up there from about 4 to 5 weeks, even though they're incredibly dilute compared with the volume of the mother's blood. And about within half an hour of a baby being born, it's been completely cleared away. So it's a very temporary thing that exists there. But you can test a small blood sample taken out of a mother's vein when a woman is pregnant and find out what sex the pregnancy is. And for some women, that helps them make a decision as to whether or not to have an invasive procedure. Because if they carry X-linked Alports, they may say, well, I'd only want to consider a CVS if I knew the pregnancy was male, for example. And that means if the pregnancy is female, they might choose to avoid the risk of having a procedure which could cause a miscarriage. And people are now starting to see if it's possible to develop a test that would enable us to look for the father's mutation. If the couple are carriers of autosomal or recessive disease, obviously the mother's mutation is going to be present in her own blood cells. So it's impossible to tell when you look at a sample whether what you're seeing is her own mutation or the same mutation present in the baby's blood. But if the father has a different mutation, it may be possible to see if there's a tiny amount of his mutation circulating in the maternal blood. But if that's a test that you would want to explore, you need to go to the genetic clinic well in advance so that they can tailor make a specific test for you, looking for the specific mutation that's present in your family. This is not something you can just turn up and ask for once you're already pregnant. So the advantages of looking for fetal DNA in the maternal circulation is there's no risk of causing a miscarriage. You may get the results a bit earlier, and it may be a less anxiety-provoking procedure to go through. But it is quite tricky to do because there's so much more maternal DNA in the bloodstream than there is in the babies. And if it's a twin pregnancy, the results will not be reliable. And when it's used very early in pregnancy, although we think the pregnancy may just be one baby, it may be that originally it was a twin pregnancy and one of the twins vanished, but a little bit of that vanished twin's DNA may still be in the bloodstream, and that can also be associated with unreliable results. So it's not entirely straightforward. I just want to say a few words about termination of pregnancy. Firstly, to acknowledge that this is always an incredibly difficult decision for people to make. And we're very well aware of the fact that for some people, this is not something that they would ever consider. But women make different decisions at different times of their lives. And it depends on a huge number of factors that we couldn't possibly discuss here, what decision they choose to make. But whatever they decide they would like to do, they will always be supported by their geneticists. And I'm also aware of the fact that although this is predominantly a UK audience, there are some people listening in today who live in other countries, and the availability of prenatal diagnosis and termination of pregnancy may be different in other countries. And so the last thing I want to talk about is pre-implantation genetic diagnosis, because I know there have been a lot of questions about this. Pre-implantation genetic diagnosis was developed because some people said, look, I really don't want to have an affected child, but I cannot face the possibility of being pregnant naturally and then having prenatal diagnosis and then having to terminate my pregnancy. Couldn't you test my embryos before I get pregnant? And actually, that's exactly what pre-implantation, or PGD, does. Patients who want to consider PGD have fertility treatment, IVF, and the eggs and sperm are fertilized in the laboratory. The fertilized egg is then biopsied. We drill a tiny hole here in the membrane around the fertilized egg, suck out just one cell or a few cells. Those cells go off to the laboratory to be tested. The membrane reseals and the embryo goes back into the incubator. And then when the results come through, we can classify the embryos as either affected, those are all marked in red here, or unaffected, and those embryos are marked in green. And then the fertility doctors can select just from the unaffected embryos and put one of them back into the womb in the hope that they implant and lead to a pregnancy. Now, this is a pin, like a sewing pin, so greatly magnified here, and that's what size an 8-cell embryo, so that's about 2 or 3 days after fertilization, looks like on the tip of the pin. So as you can imagine, this test is incredibly difficult to do. You're dealing with a tiny, tiny organism here, but the fertility specialists are now very good at being able to safely biopsy embryos. So who uses PGD? Well, people who are at significant risk of having a child with a serious genetic disorder who would not consider a prenatal diagnosis and termination of pregnancy, but who want to do all they can to avoid passing on a genetic condition. So it's only a very small minority of all those who carry a genetic condition. And PGD is acceptable to some and not to others. The decisions are very specific to individual couples. For some people, discarding affected embryos may be just as unacceptable as prenatal diagnosis and termination of pregnancy. For other people, if they're lucky enough to have 2 or 3 unaffected embryos but only use one of them, they may be very concerned about having unaffected embryos in the freezer that they're not planning to use. And these are all things that need to be discussed in great detail before people can make a decision as to whether or not this is something that they want to consider. People often say to us, what is the chance of PGD working? Well, the chance of having a live birth, if you go all the way through to PGD and you produce embryos that are biopsied, is about 1 chance in 3. If you have an unaffected embryo, if you're lucky and it's put back into the womb, then the chance of having a successful pregnancy and baby increases to about 1 in 2. So it's still only about 50-50, even if you've been all the way through the process and lucky enough to find an unaffected embryo. When is PGD most likely to work? Well, I'm afraid it's all the usual things. If you're younger, you've got normal fertility, you're not overweight, neither of you smokes, because smoking does reduce fertility. If you've previously managed to conceive, and if the woman is healthy and going to be able to carry a pregnancy successfully. When is PGD least likely to work? Well, if there are multiple genetic conditions that we need to test for, it may be that the mother carries X-linked Alport syndrome and the father has another genetic condition which they also want to avoid passing on. And unfortunately, if you don't get many embryos when you go through IVF, PGD is less likely to work. Some women are not healthy enough to carry a pregnancy, or they may not have a uterus, in which case they may need to use a surrogate. That means another woman to carry the pregnancy for them. And obviously, if women are contemplating PGD when they're single, or for same-sex female couples, they will need to use sperm from a sperm donor. There is a commissioning policy in the NHS in the UK, which means for some people, PGD will be funded by the NHS, and the criteria basically screen out people who would be very unlikely to be successful if they had PGD. The NHS wants to spend its PGD money on couples where the treatment is most likely to work. So that's females under the age of 40 at the time of treatment, non-smokers only, a greater than 10% risk in the pregnancy of a serious genetic condition. Couples cannot have previously already have unaffected children. If they do, they'll have to pay for their treatment. A woman has to have a normal body mass index. That means a normal weight. There must be an HFEA license. That's the Human Fertilization and Embryology Authority, and Alports is licensed by the HFEA, and they have to be referred by a clinical genetics department for PGD. I've put a link there, which I know Archie can put into the chat for you, of the full commissioning policy if you want to read it. So just to summarize, we've been talking about all the different options that couples can consider. I appreciate that for many people, some of these will be inappropriate or not something that they would want to think about. Geneticists will be happy to discuss any or all of these options with you. But the decisions that you make are yours. So please write down your questions, take them to the genetics clinic, and I hope that the appointments there will be helpful. Thank you.
Thank you very much, Frances. I didn't expect how do you test a fetus's urine to come up, but you just covered everything so well. Thank you. Obviously, I have a bunch of questions, both from our chat and the Q&A and social media. So if you do have any questions, by the way, chuck them in the Q&A now for the greatest chance of us actually reading them. I do want to say one thing first, that the take a chance thing, I think, if you are considering having a child, I think I say this at almost every meeting I go to, that we have a very decent community now and a huge support network, at least in the UK, and support for this condition is strong and getting stronger. So I would note that although we have all of these wonderful mitigation strategies, it is also a very valid option to take that chance. It's not something that's some lazy or negative.
That's why it's always top of my list, Patrick.
Yes, absolutely. Probably the easiest as well, I should imagine. I don't know. I've obviously got a bunch of questions. I wanted to know, firstly, are there any studies that can actually use this genetic testing that we're doing right now in order to perhaps further research in the disease? I know we've covered this a little bit in previous workshops. Could I be contributing to the research with Alport syndrome by having a genetic test and then submitting data somewhere?
So if you have a genetic test, the data is automatically, in a completely anonymized way, submitted to a database where all the results of genetic, in fact, there are several databases, but there are 2 or 3 that we all turn to first off. One in Leiden, that the lab will send their result there to you, as there are a couple in the States. In fact, one of the initiatives we're looking at the moment is also for patients to give us consent to put their genetic test results into radar, which I know increasingly a lot of patients are using, because the genetic test result on its own gives us some information, and the doctors who are doing genetic testing and the scientists are always very keen to look up and see, has this variant been reported before, and was it in somebody else who also had Alport syndrome? But actually what gives us the most information is knowledge about the genetic test together with clinical information about how is that patient affected. And getting all that information into a database like radar is going to give us an even richer resource than the existing genetic databases that we already have.
I think we have had someone from Radar on the workshop, and they were very useful in explaining why particularly some of these genetic tests take so long. I'll get to that in a second. Aura, I know you have questions as well for Frances. Would you like to kick off?
Yes, thank you, Patrick. I just had a question about, I know you said that it takes a couple of months to receive a test result from genetic testing, but how long in general will it take? Is it longer if, you know, they find a mutation, or does it not make a difference?
It doesn't make a difference because, and 2 months is the best, actually. It may well be 3 or 4 months. And in fact, with the backlog that's built up because of having to deal with COVID, sorry to mention that, may mean that it could be 4 or 5 months nowadays to screen the DNA. The problem is that when you sequence somebody's DNA, you will find huge numbers of variants, and it's a very manual process, a very labor-intensive process to go through each one of those variants and look up in all the different databases, all the publications that there have been. Has this variant been seen before? Was it thought to be significant? And then they may need to come back to you and say, can we test other members of your family to see if they've got the same variant? Because if you've got an affected brother or sister and they don't have the same variant, then that rules out that variant has been significant, and we've then got to go back and look for another one. So sequencing the DNA is pretty quick. It's pretty automated. The blood goes into a machine and the answer comes out the other end. What comes out the other end is a lot of DNA sequence, and it's that bit that's really difficult to analyze. It just takes a very long time.
A lot of questions coming in. I think it's probably a record because we've got so many patients engaged in this. I've got a question from Penny who wants to know if there's a limit to the number of cycles that the NHS will fund of PGD, and I think probably some of the other options as well.
So at the moment, the limit, the NHS will fund up to 3 cycles. But in one cycle of treatment, you may be lucky and get more than one embryo that's unaffected. So in your first cycle of treatment, let's say you're incredibly lucky and you get 3 unaffected embryos, you'd have 1 put back, see if you get pregnant. If you don't, you come back and have the second one put back. If that doesn't work, you come back and have the third. That still counts as 1 cycle because it's 1 cycle of ovarian hyperstimulation. So you may get more than 1 attempt from 1 cycle. The PGD commissioning policy was due to be reviewed about 2 years ago, and it, as you can imagine, has got postponed and knocked back by all the other things that have been happening. We have been aware of the fact that it may be that the Commission decide that 3 cycles is generous, particularly because some people get a lot more than 3 goes out of that. And so the number of cycles of ovarian hyperstimulation that are funded in future, I wouldn't be surprised if that goes down to 2, but I don't want to predict that because I really don't know yet.
Laura?
This question was asked on the chat and on Facebook, whether or not PGD can tell if the embryo is male or female, as well as if it's positive for Alport syndrome.
So it depends whether or not we need to know that information. If we do need to know it, then yes, we can find out. If a couple is at risk of having a child with autosomal recessive Alport syndrome, the sex isn't relevant, and so we wouldn't test for it. And you can't select an embryo just because you fancy having a boy or fancy having a girl. That's called social sex selection, and actually that's not legal in the UK. If you're a carrier of X-linked Alports, it may be that your decision making would be quite strongly influenced by knowing whether or not the embryo is male or female. And sometimes people say, well, can you do the sex first and then only go on and do the Alport test if the embryo is male? Or they may say, I just want to know whether or not the embryo has inherited the mutation. I don't want to know what the sex is. So we have a discussion with couples to see what do they want to know, what do they need to know, what information do we need to be able to give them so that they can make a choice whilst making sure that the choices we're offering them are legal.
Got one very practical person. We've talked a lot about the different options for Alport syndrome. They wanted to know when you would recommend actually thinking about this. I know I had my appointment with you many years ago now, and I found it very useful. But is there an age perhaps that you think is particularly useful to start educating people and making sure they understand their options with regards to Alport syndrome and genetic testing?
I've generally encouraged sort of older teenagers, 16, 17, 18, to come to the clinic because that's likely to be their first time when they're there in their own right and leading the discussion rather than being there together with their parents, so that we can at least say, look, this is what's available, this is what inheritance is, this is what it means to you. Not many people at that age are actively getting ready to have a baby now, but at least they know the clinic, they know the sorts of discussion that we have, and then we say, well, look, go away and come back when you're closer to thinking about what you want to do. And it may be that you come back when you've found a partner and you've thinking about getting together and you're beginning to think about, we'd like to have a family in a year or two's time. What we don't want, or might want to try and avoid, is people either coming back once they're already pregnant, because it may be too late to consider some of the options that they'd like to think about, or leaving it too late, because sadly, it's a fact of life that once you get older, your fertility declines, and people coming to us when they're in their late 30s or in their 40s may find it much more difficult to get pregnant. And certainly if they want PGD, they won't get NHS funding for it because it's highly unlikely to work. And so we wouldn't encourage them to consider self-funding either.
Everything in Alports as early as sustainably possible is a good idea. Aura, go for it.
This is probably one of the last questions about PGD, but somebody wants to know if there's a waiting list on the NHS for IVF and PGD.
It's a process that takes quite a long time. The treatment was completely stopped during the first lockdown, and there was a bit of a backlog that built up. But I've spoken to my colleagues in the PGD Centre at Guy's, which actually does most of the PGD in the UK. And they said there isn't a particularly long waiting list at the moment, but the process itself is quite lengthy. So the average time between having a first appointment to discuss PGD and actually getting to have an embryo put back is likely to be at least a year. So it's a lengthy process, and you have to have had your standard genetic counselling first, and you have to have had your DNA tests done first and so on before you embark on the PGD exploration.
Caught me off guard there. Joy has asked a decent question about your talk specifically. She wanted to know, you referenced ADS patients who were not known to have hearing issues. And she wondered if you could just talk a bit more about that. Does that mean that they are absolutely clear when it comes to developing hearing issues at any point in life, beyond obviously the age related hearing loss?
Not completely sure I've understood the question, but I'll try and answer it.
Sorry.
Not everybody with Alports develops hearing impairment. With X-linked Alports, hearing impairment is much more common in males than in females, but some females definitely do develop hearing impairment. They may be a little older, whereas males often it starts to show when they're at junior school age and into their teens. With women, it may be something that only presents later on in adult life, but some males and some females don't develop hearing problems at all, or they may only start to develop when they're in their 70s and 80s, and by that stage it may be that it's simply the age-related hearing loss rather than the hearing loss related to Alports. I think the point I was trying to make is that people with a single autosomal mutation, which some people would call a carrier of recessive, and others would say they've got autosomal dominant Alports, they don't generally develop Alports associated hearing loss, but that doesn't protect them from having hearing loss for other reasons.
Sorry, I stumbled a little bit there. Aura.
Just, this is more of a general question. And can you really, I know that females developing symptoms, it's quite hard to predict, but is there any way that family history can sort of help with that, or not really?
It's a very, very good question, and the short answer is no. It's funny, it's different between males and females. If you look at a detailed family history of X-linked Alport, males without treatment generally go into kidney failure within about 5 years, same age as each other. With early screening and treatment, of course, the age they develop kidney failure is being postponed very effectively now. But with women, within one family, you can have one woman who was first picked up when she was in her 80s because of the family history. Somebody tested her urine and found she had blood in her urine. It's the first she's heard of it. She's never had any problems at all. And she may have a niece or a granddaughter who developed kidney failure in her late teens or early 20s, which is, very much the pattern you see with affected males. And the way we think that we can try and explain that is it's purely this random business of how lucky or unlucky you are in terms of which of your 2 X chromosomes you switch off. And we can't predict that. And there's no pattern within families that makes that the same. So looking at the way other females in the family have been affected with X-linked Alports gives you no predictive information at all as to how you will be affected.
Yes, it's really not very helpful, is it?
No, I'm sorry.
I've got a final question because I'm conscious that poor Matt is at the coalface right now, so we don't want to take up too much of his time. My final question comes from Neil Turner, who wants to ask how common some of these techniques, particularly PIGD, are among people with Alport syndrome, to your knowledge, Frances.
It's a very small proportion of the Alports community that comes through for PGD. Having said that, of the different genetic conditions for which we offer PGD, Alports is probably in the top 15 or 20. So whether that's because Alports patients have been talking to each other and encouraging them to consider it, I don't know. So we do see a few couples each year, a small number, who come through for PGD.
So much, Frances, for answering a lot of questions very fast. I'm going to turn to Matt now for the second presentation of the night. We will get to the question on pregnancy and Alport syndrome. So if you're waiting for answers on that, please don't move anywhere. We'll address them after Matt's talk. Matt, go ahead.
Okay, I hope everybody can see that. Thank you, everybody. Thank you for the invitation. I feel very honoured. I've been a fan of these webinars for the last few months, so to hear and to be on one is a step up in my book. So thank you very much. I'm going to be talking about pregnancy and Alport syndrome, pregnancy and kidney disease in general. And I've enjoyed the webinars, which have been very science-based, clinician-based, patient-based, and today it'll be talking mainly to patients who've tuned in today. But I hope there's something for everybody. So I've assumed some knowledge, and this is this very, very helpful guides from our friends at Alport UK that can supplement this into what Alport syndrome is in more detail. And just to really summarise for people who may have turned up a little late to Francis's, that we know that Alport syndrome predominantly affects the kidneys. The commonest forms are X-linked, which means that males are more affected than females, due to a defect in one of the 3 genes we've just been hearing about, which make this rope, this type 4 collagen, which is one of the most important layers in the kidney's filters. We know that patients with Alport syndrome almost universally will have blood on a dipstick of their urine, and over time many develop protein in their urine. Progressive kidney disease, transplant and dialysis may be needed. And there's currently no cure for Alports, but very importantly, as we're hearing, therapies that can delay the onset and some newer therapies that are coming through very rapidly in practice. So, following on from Francis, I just wanted to say what I'm going to talk about when I talk about girls and women with Alport syndrome and what it is. And circa 2020, as we've just been hearing, this is segueing beautifully, Francis, as if we planned it, that we know that there are spectrums of normal kidney function up to kidney failure, hearing, proteinuria, and histological changes. And these terms of Alport carrier, Alport syndrome, some may be diagnosed with something called thin basement membrane disease. There are correlations between these findings on histological tests, on kidney biopsy tests, and the likely manifestations of these gene changes. But as we've heard, there is significant crossover from one to the other. So, for example, I can think of 2 patients under my clinic at the moment who have males with abnormalities in COL4A5 who, if they'd read the textbooks properly, should be having kidney failure and be deaf in their 20s. They're both in their 50s with normal kidney function because their variant isn't too pathogenic, isn't causing too much disease. And this concept of the Alport carrier, females with 1 abnormal copy, then there's a broad spectrum of how that manifests, the importance being that it is not a purely benign condition to be told as an Alport carrier, as we've been hearing, and the importance of maintaining that screening, that treatment is very important. And when I'm talking about pregnancy and Alport syndrome, I'm talking about everybody. I'm talking about everybody who has a change in one of their collagen 4 genes. So questions that patients may ask with kidney disease and Alport syndrome who want to come to pregnancy is, can I try to have a baby? Will the pregnancy be normal? Will it make my kidneys worse? Will it hurt my baby? Is there anything you can do to make my pregnancy more safe? What will happen after the pregnancy? So we have information on pregnancy and kidney disease going back all the way to the 1940s and 50s. These are the number of publications that squidge out on our research databases, and about 300 papers a year talk about pregnancy and kidney disease, which sounds like a lot of information. But unfortunately, about a third of those are what we call review articles. It's the same information that's already been published, being swapped around in a new way and resent out in a different analysis. So actually, when it comes to pregnancy and kidney disease, a lot of the information comes from clinical experience of people with an interest in this, sharing their information, observations, and evidence being a little lighter on the cards. And we've heard about RADAR, the UK Rare Diseases Registry, and that's a great resource of accumulating this observational information in more detail. And I hope that UK patients are all signing up to this. So when it comes to thinking, can I try to have a baby? Will it be normal? Will pregnancy make my kidney disease worse? Then going back just 45 years, which sounds a long time for the whippersnappers on the call and not so long for others, then this was published in The Lancet that children of women with renal disease used to be born dangerously or not at all if their doctors had their way. And the reason for this was that publications of pregnancy outcomes with kidney disease from the 1950s and 60s painted a very gloomy picture. And that picture was poor outcomes for babies and poor outcomes for mothers. If we look at 1950s and 60s, this is people with all stages of kidney disease, what we'd now term stage 1 to 5, then the chance of having a successful pregnancy was no greater than 2 in 3. Moving forward to our most recent large scale series, then we look at 98–99% likelihood of a successful outcome if you have kidney disease and pregnancy. Massive improvements, and that's a combination of neonatal care and maternity care and nephrological care. If we talk about patients with more significant kidney disease, a GFR less than 60 before starting, again from the 50s and 60s, it was universally unsuccessful for infants to survive a pregnancy. And indeed in this group, there was a cohort of patients, all have had what we call moderate kidney disease, CKD 4 or 5 nowadays, with no fetal survival and 6 out of 6 maternal deaths within a year of a pregnancy as well, hence that report from 1975. Again, we move forward to the most recent data. It's very likely that you'll have a successful outcome with a healthy baby at the end of a pregnancy, even with more advanced kidney disease. And being even more optimistic for the patients perhaps with the most severe end of kidney disease, those on hemodialysis, then we see that although it's hard work requiring, in this group, they're having nocturnal daily hemodialysis and accumulating over 37 hours per week, an 85% success rate of pregnancy outcomes, even on dialysis. It's hard work to achieve that, but it can be done. So in answer to a question, can I try to have a baby? I would almost always say yes to a patient. Almost always. And indeed, if you've been told no once, I know that can stick very, very severely in the brain forevermore. But the reason why it's usually yes is because as a doctor, I can tell you all the risks associated with a pregnancy, but I can't balance that up with the benefits, because only you as a patient can really assess the benefits. So it's almost always yes, and occasionally yes, but maybe not now. So will pregnancy make kidney disease worse? This isn't Alport specific, but it's intuitive that if you have milder kidney disease, it's less likely to be harmful. And if you have more severe kidney disease going into a pregnancy, then the stress may cause harm. And that's exactly what we see. So if you start a pregnancy with a creatinine less than 125 for, I think, people from overseas, that's about 1.5 milligrams per deciliter, or CKD stage 1 or 2, GFR more than 60, depending on what your most recent results tell you, then it's very unlikely that you're going to have a lot of kidney stress during the pregnancy. It's almost unheard of that you're going to lose kidney function because of the pregnancy, and it's vanishingly impossibly rare to end up on dialysis within a year of pregnancy. Conversely, if you have more severe kidney disease, creatinine more than 180, so that's about 2.5 milligrams per deciliter, a GFR less than 30 when starting, then it's very likely that your kidney is going to get stressed during a pregnancy, that some of that stress will lead to a permanent damage. And this figure here, 1 in 3 women starting a pregnancy at this level, needing dialysis within a year of pregnancy, is pretty much fixed in history. The other data showing improvements over the last few decades, this number comes out again and again that about 1 in 3 people. Put another way, if you start pregnancy with mild to moderate kidney disease, then you've got about 1 in 10 chance of needing to start dialysis before your offspring start school. And if you start with a GFR less than 50, it's about a 1 in 2 chance. So that's something to really consider in your contemplations of when the timing for dialysis is right, of when the timing for pregnancy is right, and to work through worst case scenarios, knowing that they're unlikely, but how you and your family would cope with them. Could you cope with looking after an infant whilst on dialysis? Will I have a normal pregnancy, or could kidney disease hurt your baby? So what's a normal pregnancy? No such thing as a normal pregnancy. Every pregnancy is different. So a normal pregnancy really is what a pregnancy that matches your aspirations. So conceiving promptly and easily, going through pregnancy with minimal medical intervention and observation, giving birth in a pond of water in your home with whale music without any medics around is unlikely to be the right option if you have significant kidney disease. But will a normal pregnancy be one which ends with you and your baby going home and being healthy? That's much more likely. So these are some pregnancy outcomes that we can look at and quantify. Cesarean section, early preterm delivery, needs to go to the neonatal intensive care unit for more than 48 hours, and a baby being born slower than usual. And the same pattern occurs as you would anticipate. If you have more severe kidney disease to start with, then these outcomes are more probable. So it's unlikely that you'll have a severely preterm infant born very small if you have mild kidney disease. It's highly likely, approaching 50% or more, that you'll be born before 34 weeks with a small baby needing to go to intensive care unit if you start with kidney disease, severe kidney disease. Kidney disease is not a reason to have a cesarean section, but these figures show that the cesarean section rates are high, which is an indication that pregnancies are rarely smooth. Something occurs during the way which causes concern about maternal or fetal health, leading to the pregnancy being brought to a close prior to term, prior to 39 weeks or so. So that's just an indication of what to expect, perhaps. In summary, pregnancy is successful for women with kidney disease, but the more severe the kidney disease, the more likely complications will occur. Wait a minute. Women with Alport syndrome, women with kidney disease, will on average spend 97 to 100% of their life not pregnant and not wanting to be pregnant. So we need to think at this stage, and probably a few slides earlier, about contraception, about not being pregnant. So not pregnancy in Alport syndrome. These are contraception methods: a combined pill, a progesterone pill, a progesterone injection or implant, copper coil, progesterone coil, barrier methods, fertility awareness. And with perfect use, you can see that some of these are better than others. Barrier methods, not great. These other methods, if used right, they're okay. So we can choose some options from here for contraception, and we aren't going to rely on these figures. Because if you look at typical use of these, you find that they're far less successful than they say on the tin. Because any method of contraception that has inbuilt with it the potential to forget taking it, then the rate of unintended pregnancies rockets up fairly high, particularly with barrier methods or fertility awareness methods. But we're left with the next one, an implant stayed in for years, coils are inserted, it can stay there long term, and because there's no room for forgetting or getting drunk or anything else and forgetting these, then they are highly reliable. And in terms of chronic kidney disease and use, progesterone-based contraception options are safe for just about everybody who has kidney disease. There are some concerns about the estrogen-containing compounds in that they can precipitate or accentuate hypertension, swelling, edema. They can potentially push more fluid past the kidneys. There's an increased risk of thrombosis, particularly if people have heavy proteinuria. So all these reasons make the combined oral contraceptive pill less of a favourable option if you have impaired kidney function or hypertension. And the progesterone options, there's theoretically a decreased bone density profile and some effects on cholesterol, but these are fairly minor. So in summary, really, the progesterone pills are fine, and the more modern ones have a little more flexibility. The old ones, you had to take them the same time within an hour every day, very strictly. The new ones, there's a little more leeway to make them safe. But Mirena coil and Exon implant, once it's in, There's no nor thought needed about them. Once they're removed, fertility returns fairly rapidly, and if you're old, you might want to consider more permanent options of sterilisation. So a word on contraception, because it's often forgotten, and actually that's 98% of women with kidney disease life usually. So I've spoken a little bit to say that if you have more severe kidney disease, then that's going to affect maternal and fetal outcomes. The presence and control of high blood pressure also has an effect. Protein leak seems to have more of an effect on fetal outcomes, fetal growth, although it's difficult to tease that apart sometimes. And the cause of kidney disease, what's caused kidneys to not work so well, is lower down the list, in that comparative studies of most kidney conditions comes back really to what is the kidney function, the blood pressure and the proteinuria when you're starting a pregnancy, rather than what got it there in the first place. There's a couple of exceptions. Lupus, SLE, that is a multi-system disorder where the antibodies in the bloodstream can affect pregnancy in other ways. Diabetes management in pregnancy is a subspecialty in itself, because the altered sugar levels can affect pregnancy a lot and need a lot of input. Alport reflux nephropathy, that's where urine goes the wrong way from the bladder up and causes scarring and infections, simply because pregnancy is also a risk factor for lots of urine infections. So we just need to think about that. But we've really grouped everything else in the same group and not worried so much about it. Which brings us on to Alport syndrome. So here's me and my friends in our Nottingham clinic, which we run fortnightly in the maternity unit, seeing women with all grades of kidney disease and helping them through a pregnancy. And we're all very fresh-faced and young, as you can see. And it was fairly early on in our clinic career that we had a few patients with Alport syndrome, and we noticed that we'd expect that the amount of protein in urine during a pregnancy goes up a bit. It usually doubles. But we noticed that a lot of patients with Alport syndrome, it was increasing by far more than twofold. It was going up, and they were having awful trouble with swelling and nephrotic syndrome and other things. So we started to collect a bit of data on these, and I've shared this with the Alport group a few years ago at a meeting in Glasgow. So we found 12 people with Alport syndrome or thin basement membrane nephropathy or Alport carrier status, something to do with the collagen 4 genes. And we compared them with those with polycystic kidney disease, other glomerular diseases, some structural diseases, and a mismatch of others. And they were fairly well matched for age and how many pregnancies they'd had and what their baseline kidney function was. The Alport group did have slightly higher levels of proteinuria than some of the others to start with, so they weren't perfectly matched. But when we looked at what their baseline proteinuria was and what it went to in pregnancy, then we found that for almost everybody, as we'd expect, it climbed, it increased a little bit. When we looked at the ratios of how much it climbed, though, we found that for the Alport group, it seemed to go up by an average of tenfold compared with the expected doubling in the other groups. And nephrotic range proteinuria, this is heavy proteinuria leading to some uncomfortable symptoms, particularly during pregnancy, of increased swelling around the legs, breathlessness. It increases the risk of blood clots, as does pregnancy, so we offer women subcutaneous injections of heparin throughout their pregnancy. We think it can significantly affect the blood flow in the bloodstream and then to the placenta, and hence cause other problems. And nearly 2/3, certainly over half of this group, were struggling with that range of proteinuria, which prompted some pregnancies to end sooner than normal because it was so uncomfortable. Thankfully, actually, outcomes from the babies was not too bad. It wasn't too different. So it was unusual to have small babies born slower than normal, needing to go to intensive care, and it was fairly comparable with other groups. So that's of some reassurance that having this heavy protein leak isn't having a major effect on the baby's growth, but still quite uncomfortable for mums, and we don't really know the outcome in the long term. Some women had a profile like this. So this is real data from somebody who started pregnancy with, the pink line is the creatinine. This was in milligrams per deciliter once, sort of converted it back to UK units. So a creatinine of about 100 starting pregnancy, and then during pregnancy we usually see it dip and then return to normal. But in this lady's case, it climbed and it climbed and it climbed, and it got to nearly 400 by which time she gave birth. We saw a transient improvement, but then unfortunately her kidney function then rocketed off, and she needed to start dialysis within a few months of delivery. The protein level, she did start with particularly heavy proteinuria to start with, so a PCR of about 700, about 7 grams per day, but that rocketed all the way up to over 20 grams per day, also making her very uncomfortable. So that can happen, but most patients show something like this. Here's the creatinine again, dipping down during pregnancy, bouncing back to baseline. This is real data again. Proteinuria rocketing up, scary levels, and really reassuringly coming back down to baseline again. And that reversibility is of great interest to me, really, of how that's achieved and what's causing that. So this is a electron micrograph of somebody with Alport syndrome. And we have the bloodstream here, which contains protein and blood cells and lots of other things. And the fluid in the blood drifts across this membrane, and the protein in the blood is kept from transferring across there by the integrity of this membrane. So if we're seeing more protein traverse across this membrane, it means that there's a problem with one of the layers. Alport syndrome and collagen 4. Collagen 4 is making up this layer here, the lamina densa, and we know that this is affected in Alport syndrome. So we've got an abnormal layer there already. But there are other layers which are trying to prevent the passage of protein. There's these layers of these protein, negatively charged proteins, positively charged proteins that are trying to push the protein back into the bloodstream. There's these lining of the capillary with some holes in it. There's these little protein links that are holding these cells, the podocytes, together, and there's another network of protein here trying to push that out. So if we know that this layer is abnormal throughout, and something drastic is changing in pregnancy, there must be a problem with one of these other 4 layers that's occurring during pregnancy. What is that problem? I don't know. It could be changes in blood flow. It could be change in the glomerular structure. It could be because we're having to change medication. It could be because compounds coming from the placenta are stimulating changes in the glomerulus. That's the source of another condition called preeclampsia, which matches this in some ways. And I'm very excited that I've been working with Alport UK and Rachel Lennon and colleagues in Nottingham to apply for a grant to look in this over the next few years. So I'll be very hopeful that in 3 to 5 years' time, I'll come back and tell you exactly what's going on with this. And I also am very pleased that Albertine from Utrecht I saw is on the line today and watching, because we've been in contact about this time last year about a Europe-wide collaboration to get more data on more patients on Alport syndrome in pregnancy to see how common this phenomenon really is and how the outcomes really develop. And we were planning on contributing to Alport, this European collaboration of this, which has been running in Europe, and we got caught up on March the 5th with some problems with the data sharing agreements from the UK, from Radar to European counterparts, and we're just setting about resolving those when this thing called COVID seemed to land in the UK, and it had to filter down priority lists, unfortunately. But I know Albertine is on the line, and I know Europe-wide lots of data has been accumulating on this, which would be very interesting to examine when it's available. So that's Alport's and pregnancy, and we'll go back to a nephrologist's view of guide to starting a family, hopefully to complement Francis's geneticist's view. So if it's not yet, use contraception. A surprise pregnancy is more difficult to manage. Know your condition. Genetic tests will identify the likelihood of your children inheriting Alport syndrome, and that can be an important determinant. Your kidney function, how much protein you're in, your blood pressure will identify how smoothly your pregnancy is likely to roll. So again, no matter whether you've been told you're an Alport carrier, Alport syndrome, thin basement membrane nephropathy, collagen 4A3, 4 or 5 something, have regular checks of your blood pressure, your protein leak and your kidney function with your GP, with a nephrologist, with somebody down the pub. I don't mind, but it needs to be checked regularly so that you know knowledge is power. Plan ahead. Speak to a nephrology team or ask to referral to a renal obstetric clinic in good time, 6 months at least or so before you're thinking about starting a pregnancy. So, and this isn't essential, but it's really useful. And there's lots of renal obstetric clinics around the country or nephrologists who are used to dealing with pregnancy. And the point of this is to set expectations of what a pregnancy might entail, as I've discussed. It's a chance to adjust medications to some pregnancy safer options if feasible. Is to start folic acid, which is general advice for all, and speak to a geneticist about getting your genetic tests, thinking about the options available and considering whether that's right for you. And when I talk about just medications, I'm going to lightly flag ACE inhibitors, and I'm going to leave it there, because ACE inhibitors in pregnancy don't match very well, but how to adjust your treatment is going to be personalised, and I can answer questions if people really want to know. But it's a fairly hot topic, which there's differing opinions on what to do there. Let a GP, midwife or nephrologist know you're pregnant as soon as possible. Some of the interventions about blood pressure control, about reducing the risk of preeclampsia with low-dose aspirin, about assessing your risk of a blood clot and considering treatment with heparin injections, they can be started early and should be started early to get in the system nice and fresh. Expect a successful but less predictable pregnancy, as I've said. And then this is really important. Make time for your own healthcare after you give birth. As I've shown from those 2 case studies there, so funny things can happen after your baby and placenta are out. Proteinuria can resolve and kidney function will be fine, or things can not quite settle as well as we anticipate. And if there's any of my patients from Nottingham who've joined us today, I know who you are, and I know you didn't turn up after your pregnancy. And I hunted you down, and I'll chase you and I'll find you, because it's really important that I know what's happening after your pregnancy so that we can make sure we can keep you as healthy as you were beforehand. So go to your follow-up. It takes 2 people usually to make a baby, so somebody can hold the baby while you come and see me. So what next? Well, as I said, almost all women with Alport syndrome can consider a pregnancy. And if you've been told you can't because of your kidney disease, it's worth revisiting that with your nephrologist next time you speak to them. And the role of me as a nephrologist is to describe the options, outcomes and risks, but not to tell you what the right option is. It's to support you once you've got enough information to support your decision through your pregnancy. Okay. So I'm really thankful to all these people around the country who have contributed to the RADAR group, the Rare Disease, Pregnancy and Kidney Disease group, accumulating data on over 600 pregnancies now, many of whom interact with the Alport group, and we've got an increasing coalescence of patients with Alport syndrome and pregnancies data. New collaborations looking at these new outcomes, and the support of the charities that have been instrumental in sharing the information particularly. Further information about generic to chronic kidney disease and pregnancy or contraception are available from our friends at Kidney Care UK. I helped to write one of these. I certainly didn't take contribute the pictures, which do assume that you have to be incredibly beautiful to consider a pregnancy with kidney disease, which isn't actually manifesting the case. But these are downloadable for free from Kidney Care UK. So that is my presentation. Thank you very much for listening, and I hope we have some interesting questions, and I'll be delighted to answer them. Thank you.
Thank you, Matt, for that presentation. It was very informative. Thank you. We have a lot of questions in the function, and I just wanted to start with what's the risks for the mother to have the child, to have a baby, if it's the baby has Alport and the mother has Alport? Does that make a difference?
Sure. So it doesn't seem Alport syndrome doesn't tend to affect development in utero before birth. Babies with Alport syndrome, as you know, are healthy, fine bundles of fun, maybe with a bit of blood in their urine. And in terms of the risks to mothers going through the pregnancy, as I've said, most of the time you would finish a pregnancy in a similar state to starting a pregnancy in terms of your kidney function and your blood pressure and your protein leak. However, that's not strictly true if you have more advanced kidney disease. So there's a publication that we've had accepted but not published yet, looking at kidney disease in general. And we used to think that kidney disease your kidney function got a bit better during pregnancy, in the middle of pregnancy, and then normalized out if you had good kidneys. If you didn't see that dip in the middle, that would suggest there's not a lot of reserve, and you might see a more accelerated decline. And if you had bad kidneys to start with, then the kidney stress, the pregnancy stresses the kidneys too much. What we've actually found in this new paper is that actually you tend to get a stepwise drop in kidney function with pregnancy if you have more advanced kidney disease. So it doesn't really change the angle of your progression of kidney disease, but it just shifts it forward a couple of years. So you can lose between 1 and 3 years of healthy kidneys by having a pregnancy if you have more advanced kidney disease.
Yeah, which obviously we don't really want. Patrick, did you have a question?
Oh no, I normally have one mic muted. 2 is just too much to handle. I do have a question from Shabir, who talks about being a woman with pretty much no symptoms from kidney disease, but with Alport syndrome. You showed that people who do get pregnant will have a spike in proteinuria during pregnancy. Is there a risk that that spike could cause scarring in the kidney or lasting damage, even though the proteinuria has actually returned to normal?
That's exactly the question we're trying to answer. That's the question we wanted to contribute to with the Alport study with European colleagues. Clearly, Alport syndrome in this forum is very common and frequent, but it's not in the rest of the world, and pregnancy and Alport syndrome don't meet. So we really do need all that information. And part of the work I hope to look at is whether that transient exposure to very high levels of proteinuria does cause lasting effects. And we're hopefully looking at more subtle markers of kidney damage caused by that during the pregnancy to try and answer that question. In experience that we have to date, again, if you start pregnancy with a fairly normal kidney function, normal creatinine, normal GFR, then even with those very heavy protein jumps, it doesn't seem to accelerate decline in kidney function significantly. That we can see over a time frame of 1-5 years. Longer term follow-up than that is not really available. So you can be very confident in that context. The impact of the high protein levels are more discomfort during pregnancy due to swelling and concerns about fetal growth and risk of blood clots that we worry about or don't worry about, we just address and treat. So it can just make it a bit of a murkier pregnancy, but actually if you've got good kidney function to start with, then once the baby's out, it does tend to resolve.
Great. I just wondered, somebody talked about how they had an increase in kidney function, well, a decrease in proteinuria during their first pregnancy, and you just touched on it just now about how you saw the slight decline in proteinuria. But is this common? Is this seen a lot with people with mild?
So if a decrease in creatinine, an improvement in kidney function during mid-pregnancy is normal, and that's what should happen. You get a 50% increase in blood flow to kidneys during a normal pregnancy with normal kidneys, and that manifests as an increase in GFR, so a lower creatinine. So seeing that dip in the middle, I say a normal creatinine for, I don't know, a 25-year-old woman might be 70 or 80 with healthy kidneys, and during a pregnancy we often see them down to 40 or even 30, so very low creatinine levels that then increase back towards baseline from about 30 weeks. That's normal physiology, healthy physiology, and that's fine. The comment that proteinuria decreased during their pregnancy as well, they clearly haven't read the textbooks because that shouldn't happen, but everyone's different and it depends how you measure it in some ways. So that's not the norm, but findings like that prompt more questions that we want to answer as to why that is. And part of that can be related to as I said, these placental growth factors that come out, and stress placentas squidge out more of these factors that affect the kidney, and that interaction just gets very complex. And again, in a rare disease situation like this, you just need a lot of data so that you can try and tease these apart. So interesting.
Yeah, of course, it's quite difficult to tell, isn't it? Patrick, over to you.
I've got a very simple question, actually. We've talked a lot about pregnancy, but in the case of someone that wanted to avoid it, do you have any reason to not recommend a hysterectomy or a vasectomy as a method of contraception?
Well, clearly, highly effective methods, but not reversible. See them as not reversible. So for very younger patients, by which I mean, less than 30, then I think that's an unusual choice, because you don't know how opinions may change in the future. And rather than hysterectomy, sterilisation would perhaps be an alternative option from there. For patients who have either completed a family or are confirmed in their mind after good counselling and thought they definitely don't want them, that's fine. But there are options like the next femoral implant or the Mirena coil that are very well tolerated, very effective, don't need a lot of brain to remember that they're there, and can be removed if there's a change of heart later on for females. For males, there isn't an option other than, vasectomy or not. So it just needs a good talk and a good think about what if.
Rachel's asked about the size of a kidney, whether or not this links to the risk of progression of kidney disease during pregnancy.
Maternal kidneys, mum's kidneys, I assume. So again, it's very interesting. Normal kidneys grow during pregnancy. Part of the impact of so normal, usually a kidney will be 10, 11, 12 centimetres, and during a pregnancy of a healthy kidney, the increased blood flow makes it increase by about 20%. And we don't routinely do dynamic measurements of kidney size during pregnancies, but I can imagine that if we did and we didn't see that growth, and that would again be a manifestation of a kidney that didn't have a lot of reserve, that was already working at maximum capacity and couldn't really adapt more to that. So if you have small kidneys and you're not a very small person, then that does suggest that your kidneys are perhaps more scarred, more fibrosis in there, more advanced kidney disease, and less likely to adapt well to a pregnancy. Doesn't mean a pregnancy is not possible, but it's again perhaps an indicator. I don't think it's any more sensitive than knowing what your creatinine and your GFR are.
Yeah, sure. Patrick?
I did have an interesting question about twins and whether this would change any of your advice. I'd imagine not.
Whether to have.
well, I don't think it's something you can predict, but would having twins change any of the suggestions that you've made, or would it change the outcome for your pregnancy?
Yes.
With regards to Alport syndrome?
With regards to Alport syndrome, probably. With regards to kidney disease in general, then we've got a bit more information on that. So twin pregnancies with significant kidney disease are challenging. It comes down really that the kidney disease, the medications, the adaptations require you to have a lot more blood flow, and that's mediated via the kidneys. And if you're having a twin pregnancy, then you need a double-powered placenta to be able to give them the nutrition that they need. So again, it's predictable that if you have advanced kidney disease, blood supply and blood increments in blood volume are going to be diminished, and therefore it's less likely that you're going to be able to adequately provide the nutrition to twin pregnancy later on, and it's much more likely that might end at 34, 33 weeks earlier than that perhaps. There's also an increased risk of the placenta getting very stressed and giving out all these hormones that cause a syndrome that we call preeclampsia, and that can be early as well. So I've got personal experience of looking after a lady with moderate kidney disease, heavy proteinuria with diabetes, who had twins, and she did exactly as we'd anticipate. Lots of proteinuria, difficult pregnancies. She was uncomfortable for a lot of it. We started to see tailing off of the baby's growth at about 32 weeks. She delivered. I saw her today, actually, serendipitously, and the two kids are 8 years old and appropriately irritating, according to her. Yeah, lively 8-year-olds getting in the way, doing everything that they just to annoy her, which is a perfect outcome, isn't it? Really. Yeah, so again, difficult pregnancies, but good outcomes.
I've got a final question. I'll let Aura can have the last word on this one, but I wanted to ask a final question about successive premature pregnancies. So Victoria's asked if her first child was born at 21 weeks, would there be a risk to having a second one, and would there be certain considerations associated with that?
Sure. So you can imagine, I'm not an obstetrician. I don't deliver babies, and you can imagine there's a whole different groups of reasons why pregnancies might not make it to term. So that can be due to the uterus and the cervix. It can be due to preeclampsia, which is fairly unpredictable. Who will or won't get preeclampsia, where the placenta gets stressed, and that can lead to an early pregnancy. And of course, it depends on comparing. If your previous pregnancies, what was your kidney function, proteinuria and blood pressure when you started that one? Has that changed to now? if you had very severe kidney disease here and then you had a kidney transplant and that's working beautifully and then you have a pregnancy, well, your risks are lower. If you had kidney disease here that's then progressed and is now worse, then the risks can be higher. So there's absolutely no rule that says that one pregnancy predicts the next pregnancies. Again, personal experience of managing people who had very preterm delivery because of preeclampsia or because of premature rupture of membranes at 28, 29 weeks. Second pregnancy got through to 36, 37 weeks without any problems at all. But the converse has also happened. Not very helpful answers again, but it's more likely that you'll have a preterm delivery if you've had one before because your body has some of the same risk factors.
I think Francis would remind us that chance has no memory, I guess. Or sorry, your final question.
Yeah, my final question, I think probably both Matt and Francis might want to discuss about parents. Should they consider freezing their eggs?
So freezing their eggs, and Francis will be more expert on the other side of that from here. Freezing eggs is useful for patients who want to have a baby but not yet, and they're going to have a period of their time when their fertility could be damaged, or a time when the timescales are such that waiting for nature to resolve the issues that's making it not the right time now could be helpful in the future. And in terms of kidney disease, well, kidney disease itself doesn't really affect ovarian reserve, how many eggs you have. It can affect ovulation and it can affect pregnancy successes. So it's unusual from just a nephrology perspective as a kidney doctor to recommend that people have eggs frozen because they're going for a transplant, because they're starting dialysis, because their kidney function is deteriorating. That wouldn't normally be the case. Indeed, the only situations where I really suggest it or talk about it are cases where people are requiring therapies for kidney diseases that can damage ovaries. And the classic is cyclophosphamide, a therapy that's commonly be used for SLE and is sometimes used for vasculitis treatments. And in those situations, we do talk about egg preservation and egg and ovarian protection. But Francis, your thoughts on that?
Well, we guessed we might get this question, didn't we? So Archie, there's a couple of links I've sent you. Maybe you can put into the chat function. The National Council on Bioethics, of which I'm a member, produced a short document about a month ago looking at the issue of egg freezing. And the reason it did that is that although egg freezing for medical reasons, for example, for people who are about to be made permanently infertile because of treatment for cancer, can be useful, and sometimes people may have no alternative to that, there is increasing pressure from society at the moment for people to consider egg freezing for social reasons. And there's concern about the amount of marketing pressure that there is on women trying to persuade them to defer childbearing so that they can get on with their life and their career and so on, even to the extent that some companies are offering this as an employee perk, and some private clinics are promoting this, Prosecco parties and things like that. And there's a lot of concern about the way this is being marketed. So I think if people are thinking about egg freezing because their nephrologist is raising it as a discussion and something that could be sensible, then it's very wise to go and discuss with the fertility clinics what the options are and what the chances of success are, because it doesn't always work. You can't regard it as an insurance policy. But I think if people are thinking about it because they feel that they're not at the right time and place in their life and so on, what they need to be aware of is the fact that the vast majority women who freeze their eggs for more social reasons never come back and use them, and it's very expensive. So they're spending thousands and thousands of pounds for something that they will never use. And of the tiny minority who do come back and use those eggs, most of them don't get pregnant. And the main reason for that is that they tend to leave it too late. So the average age women are freezing their eggs these days for social reasons, 38. And if you're going to freeze your eggs at a time when you still have good fertility, you need to do it before the age of 35. So it's a complex issue. By all means, have a look at the resources, the Nuffield Council leaflets, and also an online debate, a webinar a bit like this that was held 3 or 4 weeks ago, where there's some interesting discussion. And talk to your nephrology specialist, talk to the fertility doctor, but don't get persuaded or pushed into doing it by other people who may have other incentives to be wanting you to consider that. It's a very personal decision, and it can only be made when you really properly understand the facts, the risks, the costs, and the chance of it working.
Great, thank you for both answering those questions so well. Patrick, did you want to just finish up?
I think, yeah, sure. I think like many of the things, could probably deserve its own Alport all sorts seminar at some point, if we feel it needs it. Thank you so much to both of our speakers. We've answered about 1 billion questions today and provided so much clear information about a very important topic. If anyone does have pressing questions that they still want answers, and I'm going to give you a Facebook group in a second, go on there. There is a post that I've posted. Just ask the question on that and we will get it to our experts, I promise. We do want to finish with some feedback, if that's okay. I know it's late, but we would love to finish with a word cloud, which Archie is about to paste into the chat now. Basically, we just like you to sum up how you're feeling. Having watched the workshop today, I'm sure we're going to get lots of very positive stuff out of it. I'll go and contribute myself as well. It's important to us that we get this feedback so that we know what to focus on in future. I know this is a little bit different from what some people may be used to. We've tried to push this workshop towards patients a little bit more. We know that you guys get a lot out of keeping our talks accessible. Informed, I think the top one. Ready for a baby. Oh my goodness. I'll give it a few more years, but I'm definitely more confident about the facts. Empowerment, so informative. Informed, I think the word of the day there. Okay, thank you very much, everyone. Thank you so much, everyone, for coming today, asking all of your questions. Do let us know if there's any topics or research you would like us to cover in our future workshops. Our upcoming workshop will include the latest research on flozins, SGLT2 inhibitors, as they are formally called, and we are planning to end the year with an online celebratory event, hopefully on Zoom. Details to follow, but it would be lovely to get the community together to celebrate all that we've achieved this year. Before we wrap up, I want to particularly thank Francis and Matt. Matt, who still has to get home today. He's been incredibly patient. Francis, once again, for giving up her time whilst her grandkids no doubt tear up the floor below her. And of course, Aura for helping me ask questions and giving me a bit of time to think as well between them. Thank you. A massive thank you has to go to Kidney Research UK for your sponsorship. You help fund our Zoom subscription, and they, of course, keep the lights on at these Alport workshops. This charity, they've supported us for years, right back to the first workshop we had. They're the ones that enable us to keep you well informed wherever you are, and they help us bring reliable information to you. So thank you to Kidney Research UK. If you do have any more feedback about this session or want to be added to our mailing list, email us research@alport.info, or email us anywhere. I know Mum loves talking to you all. Please follow us on social media as well to hear updates about our workshops as they happen, and of course details about upcoming research and in-person workshops whenever they are allowed to happen. Patients can join the Alport Warriors Facebook group. That's where you'll find the post today asking for questions. And of course, anyone can hit us up on our Twitter page. That's @Alport UK. Finally, we will get a recording of this talk up on YouTube in a few days' time. If you missed anything or want to go over something again, you will absolutely be able to do that. Otherwise, thank you all so much for watching over what's been an amazing couple of hours, and have a lovely evening.